Hi, my name is Kevin Campbell. I'm a urologist with the Urology Group in Greater Cincinnati, specializing in male sexual health, and appreciate you guys taking the time to join me this evening for our talk. I'm going to be talking about erectile dysfunction, and we'll cover several different topics in that area and try to answer any questions if you have them available. I trained at Ohio State many years ago. There weren't fellowships when I trained. And so when I got interested in sexual medicine, I sort of went to the experts around the country and learned a little bit from this person, a little bit from that person. And then with many years of experience, I've been doing this and enjoying it for quite a while. Still do general urology, but the focus of my practice is on men's sexual health. So we'll start out by talking about erectile dysfunction. And I guess the definition of erectile dysfunction is the inability to have an adequate erection for penetration. And one of the questions I get from people all the time is, doctor, sometimes I get a good erection. Sometimes I wake up at night with an erection. Erectile dysfunction doesn't have to be zero erections. It's just I don't get erections when I want to. Sometimes I get them, sometimes I can't. It's frustrating for me and my partner. So, I do see that a lot, that people think, occasionally I get an erection, I must not have a problem. But it's just an inability to consistently get an erection when you want to get it. Very prevalent. As we'll talk about here in a minute, when you think about an erection, when I think about an erection, basically it's your penis filling up with blood. So any disease that affects blood flow is going to affect the ability to get an erection. So the things, we commonly think about, high cholesterol, smoking, stress, out of shape, those things significantly affect blood flow, and therefore they're going to affect trouble with erections. And again, it's a pretty prevalent thing. Certainly as we get older, things change, including testosterone, cholesterols go up, blood vessels aren't quite as nimble as they were at a younger age. And so there is definitely an association with age as well. So we'll talk first about normal erectile function. So it starts in the brain, and there's nerves that connect our brain to our penis. And those nerves, unfortunately, go right next to the prostate. And that is why if you've had prostate cancer surgery, radiation therapy to the prostate, maybe colorectal surgery, often those nerves will be damaged. And so we, as urologists, unfortunately cause erectile dysfunction as well as treat it sometimes. When the nerve gets to the penis, it basically causes muscle relaxation. So that's really what happens, is relaxation of the muscle. And in the penis, there's an artery. And when the artery relaxes, it gets bigger in diameter, and therefore you get more blood flow. And then inside the penis, there's these small little, what we call ponds, I guess. There's a fancy medical word for it. But basically, when they relax, these small ponds turn into lakes, and you get an erection. The two cylinders in the penis expand like balloons. So you get expansion in diameter and expansion in length. There are some compression of the veins as well. It's a little more sophisticated, but the end result is you don't get blood flow into your penis. So again, anything that correlates with what we think of as, in the pictures here, bad, poor health. So anything that causes vascular disease, unfortunately, sometimes that's genetics. You can just, your father, your grandfather had blood vessel problems, and you're going to have them. Diabetes can affect erections in a couple of different ways. It affects nerves. So, you get neuropathy with diabetes, but it could also affect blood flow as well. And so very commonly, people who are diabetic have, go on to have trouble with erections. And then again, anything that we associate with blood vessel disease, obesity, smoking, stress, all those things we think about with heart disease definitely go on and can cause trouble with erectile dysfunction. In fact, when they've actually done studies that have diabetes, men who have diabetes and trouble with erections, significant percentage of those men do go on and have trouble with heart disease as well. So how do you reduce your risk for erectile dysfunction? The things that we commonly think about: we keep our weight under control, we don't smoke, we watch stress, alcohol can be bad, all the things you think about, sleep, anything that you associate with being healthy, it's going to help erectile dysfunction or erectile function. And, things that we associate with, poor health, erections are a pretty good barometer of your health, actually. We already talked about urological issues related with prostate cancer. Low testosterone, I'm going to talk about. That's obviously an incredibly popular topic. We used to think low testosterone only affected libido or sexual desire, but that's not true. It can definitely help erections as well when we supplement it if it's low. So if you come to see me and you've never had your testosterone checked, we're going to do that. If the pills haven't worked to your satisfaction, the first thing we do is add testosterone. Peyronie's disease is a disease that affects the cylinders. Remember the cylinders that fill up with blood, and it's basically causes plaque formation or scar tissue on the surface of the cylinder, which classically results in a penile curve with erections, but also is associated with blood flow abnormalities, usually what we call venous leak, that can contribute to erectile dysfunction. Although I see many, many men who have Peyronie's disease who have absolutely no trouble getting or maintaining erections. So it's not, as much of an association maybe, but certainly can be associated with it. So let's talk about testosterone for a few minutes. We know why testosterone goes down as men age. There's cells in the testicle, and they diminish in number. Testosterone is metabolized from cholesterol, and there's 5 enzymes that involved with that transformation, and the enzyme activity goes down. So we know why testosterone goes down. Is it wrong or abnormal or dangerous to keep it normal? I don't think so, because we do it all the time. Why does it affect erections? Well, it definitely can affect libido, that's for sure. But it also affects smooth muscle in the penis somehow. They're not exactly sure the pathways. So again, if your testosterone's low and we do something to raise your testosterone, not 100% of the time, but frequently we do see some improvement in erectile function. And so that's certainly something that we do very commonly. Again, if you've had prostate cancer surgery, radiation, where you have a nerve injury, then it's less likely to have an improvement. But definitely, we see in treatment with low testosterone all the time, the symptoms, of low energy, the things you see down here on the screen. The problem with those symptoms is they're very nonspecific. So, all those things aren't always, due to low testosterone. And, I have guys have low testosterone. I treat them. The numbers look great. But clinically, they say, gosh, I don't feel any different. I'm still tired. I'm still depressed. I still have no libido. So obviously, those symptoms have many, many different etiologies or causes. But again, if you see me, we're going to check your testosterone. If it's even close to being low, we're going to do something to raise your testosterone. And so what I tell patients that come and see me, I know I can raise your testosterone. I don't know if that's going to make a difference, but we'll find out. Usually with erections, it probably takes maybe close to 3 months to really see an improvement. Libido, however, would be treated pretty quickly. There's different ways to raise your testosterone. There's oral medications now that you can use. There's something called clomiphene, which is used commonly in women with fertility issues because it does the same thing in a woman as it does in a man. It sends a signal from our brain to say, work harder. In a woman, that's an ovary, and a man, that's a testicle. But we use clomiphene very frequently. The nice thing about clomiphene is it doesn't affect sperm count. So if I put you on testosterone, your sperm count's going to go low. For many, many men that I see, that's not an issue. But certainly younger men or a man who's still interested in having children, we wouldn't want to give them testosterone, but we can give them clomiphene that can raise your testosterone without affecting sperm count. There's topical testosterone products. We use a lot of them. We used to use compounding pharmacies, and then we decided to have our own compounding pharmacies. So we make compounded products. And the reason we do that is because you can make them so much stronger or more potent than the things you get at CVS or Walgreens or a typical pharmacy. So we use topicals a lot. There are pellets, there's injections, and we use all those. We tend to use those later because they have a little more risk, still very safe, but because of increased risk of making your blood a little too thick. Sometimes you have to monitor the shots a little more frequently. So we typically start out with either pills or topicals. Each one of those will work about 80% of the time in terms of raising your testosterone. If you're one of those rare individuals that, they don't work, both of those, then certainly we do shots, and shots will always work. And so it's something that we provide at the Urology Center. We do lots of testosterone and monitor it all the time. Peyronie's disease is another thing that I see very frequently. And again, as I've already described, it's scar tissue on the surface of the balloon. So what happens is you get a non-uniform expansion. So basically, as those cylinders in your penis expand with blood and they get bigger in diameter and longer in length, you're going to get an alteration where one side expands, but the other doesn't. So you get a curve. You can get a curve. The other thing would be loss of length, sometimes bottleneck deformities, and those are all due to scar tissue affecting the surface of these balloons that fill up with blood. It's typically a disease of middle-aged men. We think it's from little trauma to the balloons during intercourse, and we know that because there are some men that definitely have that history where I was having intercourse or sex and I felt pain and suddenly it got bruised. And then later I developed a curve, but that's only like 20% of men. Most guys have no history of that. To say, hey, one day I walked in and next thing I noticed my penis was curved. There are things that we do for that. There's an injection of a drug called Xiaflex. And I always tell people there's very few people in the world that have used Xiaflex longer than I have. And that's because the Urology Group was one of 12 institutions in 2007 that actually were involved with the clinical trials that allowed Xiaflex to be approved by the FDA. And so I was doing Xiaflex, too many years ago. But I don't love Xiaflex because it's kind of expensive. It requires a lot of visits to the doctors. But I do it. We do Xiaflex. I do a lot of surgery for it. And the surgeries are a very, very good option. In fact, probably what I think would be the best option. But Peyronie certainly is more associated with curvature, but can contribute also to troubles with getting or maintaining erections. Again, prostate cancer treatment is because of the nerve injury primarily. And again, it's the nerve that connects our brain to our penis. And unfortunately, it's right next to the prostate. And I don't care who does your prostate cancer surgery, how great they are. If they don't tell you it's a 50% chance risk, they're probably not being completely upfront. So a significant number of men who get prostate cancer surgery are going to have troubles getting or maintaining erections. Not everybody, but at least 50%. Same thing with the radiation, although radiation typically will affect the nerves over a longer prolonged period of time. When you get radiation therapy, probably 50% of men down the road, but it can take up to 5 years, will later have also trouble with erections. And then cryotherapy, proton beam, anything that's you think about it, it's going to kill prostate cells, which is what radiation does, cryotherapy, proton therapy. Anything is going to potentially damage the nerves. So if you get problem with nerves, you're going to have subsequent trouble with erections. Okay, so let's talk a little bit about treatment options. And one of the nice things that I like about treating men with erectile dysfunction is I know something will work. So what I try to do is just discuss treatment options, because obviously this is a quality of life issue. This isn't brain cancer. You're not going to die from it. And so some person might say, you know what, I understand that, but we're good. I don't want to do anything. And I'm fine with that too. So we just want to make sure that the information that you're basing your decision on is accurate, good information, but something will work. And so, we try obviously with the simple, cheap things. And usually that's oral medication. So obviously everyone's heard of Viagra, Cialis, those drugs now have been out for close to 20 years. The good news is they're generic now, so they're pretty inexpensive. We also sell them at our pharmacy at the Urology Center for about $1 a pill. So they're pretty affordable for most people. Unfortunately, they don't always work. And in those cases, then, we go on and do other treatment options. Vacuum device, we'll talk about ultrasound or shockwave therapy, injections, and penile implants. I assume we're going to go through all these. So yeah, Viagra originally came out for the heart. So it's actually good for the heart. The only contraindication with Viagra and the heart is the use of nitroglycerin. And that's the only reason for that is because nitroglycerin and Viagra are very similar, but it doesn't cause heart damage at all. And even if you said, I've had a heart attack or I've had stents put in or open heart surgery, you can still use Viagra. Like I said, it's certainly good for the heart. The only exception would be if you take obviously nitroglycerin, or there's some long-acting nitrates that people take, and those would not be indicated. Those would be a contraindication taking the pills. You know, pills usually work for most younger men, especially. Now, again, if you're diabetic, if you've had prostate cancer surgery, usually the pills don't work or often don't work. Sometimes the pills will work for years, and then whatever disease is going on sort of continues to progress. And then eventually I see guys that say, hey, pills work for 5 years. They're not working anymore. They are rarely covered by insurance, but again, today that's not usually an issue because they're fairly inexpensive. You can get headaches. You can get flushing because they're vasodilators. They're going to cause the blood vessels to dilate. But less than 5% of people will not take the pills secondary to side effects. Again, you take them, usually 30, 60 minutes before you want to be sexually active. Cialis does have a low dose daily pill where you can just take every day. It doesn't have to be taken on an empty stomach, but if you take it with a big meal, it won't work as well, or it takes longer to work. We have a pharmacy again, the Urology Center. All these medicines we prescribe. The beauty of it, we can ship them and mail them right to your house, and they're very affordable, very low cost. Vacuum devices basically are, let's see if they have a picture here. Yeah. So a vacuum device is kind of what it looks like in a picture. You put this cylinder on your penis. It creates a vacuum, which allows blood to be, gone into the penis. Your penis gets full, and then you slip a band at the base of the penis that causes that blood to maintain when you take the cylinder off. Now, rarely do we use these, and rarely do we use these because the honest answer is hardly anybody likes them for a variety of reasons. Number one, anatomically, those cylinders that fill up with blood are twice the length of your penis. So they go way inside of you. And when you use a vacuum device, you're only getting some blood in the distal half, let's say, of the penis. So it just has to do with the mechanics, but it just doesn't work well. Rarely do people like them. It's usually pain when you have an orgasm, but it's certainly something to try. Unfortunately, it used to be covered by Medicare. It's no longer. So, you can get a few, you can get one for several $100s. After prostate cancer surgery, a lot of times people will use these just to try to maintain some blood flow into the penis so you don't get loss of length. But it's not something we use frequently. Ultrasound shockwave therapy, if you listen to WLW or Men's Talk Radio or look at the paper or radio or TV ads, I'm certainly you see evidence or advertisements for shockwave therapy. So let's talk about it. Shockwave therapy has been around the world for over a decade, and it's been used in many different institutions in Greece and Israel and Europe. And the premise is that you're sending a signal of energy, a shock wave into the tissue that causes the cells to form what's called stem cells that basically the bottom line is going to improve blood flow by producing new blood vessels. So it sounds great. It's what we call regenerative medicine. And I think big factor is that you're actually curing people rather than treating people. So obviously it has potential benefit, and certainly people would raises a lot of people wanting to be involved with this. Now, the fact of the matter is there's still a lot of unknowns about it, and we do offer shockwave therapy with Alma Duo. We just have done it in the last year or so, and the reason being is that there still is a lot of unknowns about it. Who's a good candidate? How long will it work? There's all kinds of machines out there. And so we really took a lot of time in making sure that we got a machine that we thought would work well. And And we're a third of the cost as any of the other outfits out there. So the things you hear on the radio, they're really not shockwave therapies. It's what's called a radial wave. It just has to do with the physics of the wave. They do that because it doesn't have to be administered by a physician or supervised by a physician. So the machine that we have is the best machine. It has the most data around the world. It's a true shockwave machine. It's a third of the cost as anybody else. But after saying that, we can't guarantee it's going to work. And if it does work, we can't guarantee for how long it's going to work. My own feeling is it's probably not a good option for someone, let's say, who's had prostate cancer surgery. Probably not a good option for someone who is using injections to get erections, or hasn't had an erection, has multiple medical problems. Probably guys that maybe the pills kind of work, or they still kind of get erections at night. Occasionally I get an erection, occasionally. I think more of a milder case of erectile dysfunction, that's really who the better candidate would be. But it's certainly, I think we're just in the beginning of it. And I think as time goes by, the technology is probably going to improve. And maybe 10 years down the road, we'll be doing shockwave therapy on everybody. Not quite there yet, but it certainly has a lot of potential. Just a picture about shockwave therapy again. And the idea then is mainly you're trying to stimulate the growth of blood flow. I already talked about shockwave therapy. Why the Urology Group? We've already gone through that. It's a better machine, has the most data, and we're a third of the cost. So it's the other thing that we do, I think, in our group is we provide a whole spectrum of care. We do testosterone therapy, we do oral medications, we do shockwave therapy, we do injection therapy, vacuum devices, and finally penile prosthesis. So rather than just going an outfit, the old saying, when you're a hammer, everything looks like a nail. You go into these guys, they're going to want, get your sign on the dotted line. And rather than really explaining the options, who's really a good candidate for this. And I think that's the kind of treatment, care that you can get at a place like the Urology Group. Now, I do a lot of injections, and an injection is where I would teach you how to give yourself a shot in your penis with a drug that's going to give you an erection. And most people are like, no way. But we do a lot of injections for the following reasons. Number one, injections work about 80% of the time when the pills don't. They're not that expensive. And most people say, you know what? When I do the shot, that really wasn't that bad. I didn't really, hardly felt it. So if you come to see me, usually you're going to get an injection unless you just say, I absolutely positively do not want to do that. But if you come to me and we've tried the pills and they don't work, your testosterone's normal, or we make your testosterone normal, it doesn't help, I try to get you to do an injection, because I have guys that have been doing injections for 10 years. They come in once a year. How's it going? Great. How you like the injections? Love them. Good. Here's your script. I'll see you next year. Now, after saying all that, I would say less than 50% of men will stay on injections for a variety of reasons. Lack of spontaneity. Sometimes the drug hurts. It's not the needle, but the drug itself will cause a painful erection. Sometimes variability of the results. Hey, sometimes it works, sometimes it doesn't. We get frustrated, or we travel. I mean, there's a whole litany of potential reasons, but I always try shots. I think it's something that I would do if it was me and it worked, if the pills didn't work. And it's certainly something that we do a lot. Yeah, you can get prolonged erections, but when we do it, we make sure that doesn't happen. We give you shots, believe it or not, that can make the erection go away. And usually we're able to titrate up something that we're able to do, that's going to work to your satisfaction. Does need to be refrigerated. We get these from compounding pharmacies as well. We don't use them or do this at the Urology Center, but there's different ones. Nees Pharmacy in Northern Kentucky, Tri-State in Greater Cincinnati. They do have a limited shelf life, but you can still use them when it says it expires. It just, the dose itself won't be quite as good. I'm going to spend the rest of the few slides just talking about penile implants. And I do a lot of implants. I like doing implants, and we'll talk about it tonight. The first part of the talk, I said, I know something will work, and that's the case. I know a penile implant will work if nothing else does. So, it is a surgery. It does take about an hour to do. It's an outpatient surgery. Most people, this says 90+%. I think that's a little optimistic, but I would say 80 to 90% of people who get a penile prosthesis are happy with it. And the success of the surgery, I always tell people, is not me doing it. I mean, I've done many, many penile prosthesis. It's you saying, I like it. I'm glad I did it. I would do it again. And that's about 80 to 90%. Do I do that first? No. Because I do quite a few prostheses. Let's just say I do 50 a year. And if the satisfaction rate is 80 to 90%, that means 5 to 10 of those people may not like it. And, normally it has to do with penile length, because with a prosthesis, you do great at diameter expansion, great at rigidity, but not quite the length that you did with a normal erection. So you come to see me, we do shot or we do pills. So unless you've already tried pills, they don't work. We do testosterone unless it's normal or you've already tried testosterone and it hasn't helped. We talk about shockwave therapy and the appropriate candidates. I strongly encourage injection therapy. But you know what? If none of that stuff helps, then we do penile prosthesis, and we do them because they work, because you're able to get a good erection. You get really good spontaneity. You're able to pump this thing up. And I do quite a bit of them. Let's see if we got a slide here. So basically, what we do with a prosthesis is we put cylinders in your cylinders that instead of filling up with blood, there's a little pump that you squeeze and it fills up with salt water. It takes about an hour to do. It's typically outpatient. We do them at the Urology Center, but I did one today at one of the local hospitals. Infection rate, we always get worried about infection, but the reality is infection rate today is, 2% nationally. In my own hands, it's less than 1%. Not to say that I haven't had infections, I have, but it's very, very low today. Mechanical malfunction, 85% are still working just fine at 10 years, but I've also had to go back and fix them at 5 years, where basically you get a crack in the tube somewhere. It's salt water, and the salt water leaks out. It's a hydraulic pump, so it just doesn't work anymore. The only way to fix that is to do another surgery. Insurances normally cover penile prosthesis. Medicare covers penile prosthesis. Most insurances do cover penile prosthesis. And the reason, honestly, is because when you look at how many men have trouble with erections, a relatively small percentage of those men will go on and get a penile prosthesis, either because one of the other options will work, or just they're like, you know what, we're good. I don't want to do the surgery. It is a surgery, but I do a lot of them, and I do a lot of them because people like them. Again, it's a good patient satisfaction because it works. People always ask me about sensation. Does it feel the same? You wouldn't have 80 to 90% of people say they like it if it didn't feel the same. Sensation is skin, which is unchanged, and it's an orgasm, which is unchanged. So both of those things will still work, and most people like them. The biggest source of dissatisfaction is length. I always tell guys, stand up in the mirror, take your penis and stretch it out. That is going to be approximately the length of your penis with a penile prosthesis. And again, I go through that because that's the biggest source of, I don't like it. I thought my penis was going to be longer, things like that. Anyway, I think that's pretty much it on my talk. So let's see, do we have any questions here now? Okay. Have you had patients move from shots back to pills successfully? Not usually. Usually, if you try the shots, we've already tried the pills. It's possible. Let's say you've had prostate cancer surgery and you try the shots originally, sometimes, but not usually. Recovery time from Alma Duo is none. I mean, there's no recovery. That's the beauty of it. It's quick. It absolutely doesn't bother you, but you can have it done and literally walk out the door and do whatever you want. I tried pills and vacuum pump. Nothing seems to work. Then basically, if you come in, we will do something to work. Either shots will work, shockwave therapy will work, or I guarantee the penile prosthesis will work. Length with the implant is again, yeah, the best erection you ever had in your life will be your normal erection. But a penile prosthesis is pretty good, but the length is what I said. Take your penis, get in the shower, stretch it out. That's going to be approximately the length of your penis with an implant. The cost of Alma Duo, I think, is around $2,000 with us, and that compares with about $6,000 with the people you hear on the radio. Is there a step that considers mental fitness before going to a penile implant? We don't do formal psychiatric or psychological testings. I mean, look, I spend time with people. I talk to them. I ask them, do your partners want to be sexually active? And we don't do any formal mental fitness testing, I guess, before an implant. So is testosterone a fuel to treat prostate cancer? No, it's not. In fact, today, a third of the men that we do prostate biopsies that show prostate cancer, we don't treat. We don't do radiation or surgery or anything. We say, yeah, you've got some cancer. It's slow growing. We're just going to watch you. And that's 30 to 40% of men. They've actually done studies and take that group of men and give them testosterone, and they do just fine. So making your testosterone normal does not promote prostate cancer, does not promote the spread of prostate cancer. And in fact, I don't know, there's actually some new data saying if your testosterone's normal, you actually do better when it's metastatic prostate cancer. Now that's just hot off the press. That's really new stuff. But no, we treat guys who've had prostate cancer all the time with testosterone. Are implants good for those who've had Peyronie surgery? Yes, 100%. But when you have Peyronie surgery, you probably have already lost some length maybe. But yeah, I do. Sometimes I'll have patients that have Peyronie surgery to make the penis straight. And then for a while, they get great erections, no trouble. But then later on, the erections aren't as good anymore. And I've certainly done implants in them. And then there's some guys that I'll do a combined procedure. I'll do the penile prosthesis and application or something to correct the curvature at the same time. Shockwave therapy, again, I believe is $2,000. It's not covered by Medicare. Shockwave therapy isn't covered by Medicare. Interestingly, Medicare doesn't cover medical therapy for erectile dysfunction. So pills are not covered. Injections are not covered. Shockwave therapy is not covered, but a penile prosthesis is covered. And again, it has to do with what percentage of men are really going to get a prosthesis versus try pills, shots, etc. What's the recovery time for after a penile prosthesis? I mean, look, you're sore for a while. I mean, what I typically tell people who are still working is do it on a Friday. You're going to take the next week off. Tell them you had a hernia operation. After that, you can go back to work. I mean, you're still sore. So I usually see people back in 2 weeks and 4 weeks and 6 weeks. In 2 weeks, you come in and you say, hey, man, I was pretty sore. And I look at it and say, looks perfectly normal. I'll see you in 2 more weeks. So usually by 4 weeks, all that soreness has gone away. And then at that point, we start teaching you how to inflate it and deflate it. If you look at patient satisfaction, again, with prosthesis, it's 80 to 90%. It takes 2 to 3 months to get there because you can't use it for a month. And then it usually 4 to 6 weeks before you can really start pumping it up. And then it takes another 4 to 6 weeks to really get used to inflating and deflating it. But, but if you're still working, you're out there, I would say you're still going to need, 10 days off. On my first visit, we'd be checking my prostate and how so. So, if you go see a urologist, you usually get a rectal exam. We feel, basically with our finger, putting our finger in your rectum, we're able to feel the prostate. And when we feel the prostate, we're really feeling for cancer, hardness, firmness, induration. And then we usually get a blood test, which is called a PSA, which is a blood test that looks for prostate cancer. And usually that's how we check for prostate cancer. Another question. Somebody who's tried pills, injections, shockwave therapy. Yeah, this guy needs a penile prosthesis. He's a perfect candidate. Nothing's worked. He's tried everything. Certainly we could check his testosterone, but if he's already tried injections and that hasn't worked, unlikely testosterone, this is a perfect candidate for a penile prosthesis. Alma Duo, how long does it take to complete the series? I think it's once a week for 6 weeks, but I think our monitors may have a number you can contact to get all that information. Yes, so many still take pills after Alma Duo. That's correct. Alma Duo shockwave therapy right now in 2022 isn't the cure-all. And if you said, I take Viagra or Cialis, but it doesn't work to my satisfaction, and you had shockwave therapy and you came back and you said, hey, the pills work great, I would consider that a success. Now, maybe you wouldn't, but so I think it's a degree of satisfaction that you're going to get with Alma shockwave therapy. No, the cost of shockwave is $2,000 for all 6 treatments. Will an erection ever come back on its own after prostate surgery? Sometimes, but a lot of times, no. I mean, even if you can get an erection, sometimes you definitely take a hit. So this is a more sophisticated question on shockwave therapy with low intensity shockwave therapy versus focalized linear compression therapy. So that's the issue with all this technology, is that there's different machines that have different ways to deliver the energy. Is it better to be more focused, or is it better to be unfocused? Is it better to be a true shockwave, or does a radial shockwave work? And yes, there's differences. Do we know which one really works better yet? No, we don't. And that's one of the problems with this whole field of shockwave therapy. There's still a lot of unknowns, and all the studies that have been done all around the world were with different machines, different shockwave energy levels, different protocols. And so there definitely is definitely a lot of questions still. Is an enlarged prostate related to ED? Not really. Can you take more than one pill at once? Yeah, I mean, when people say the highest dose of Viagra is 100 milligrams, and they ask me, can I take 200 milligrams? And I say, I don't know. It's never been studied. But the reality is people do it all the time. And most people, you're not going to die from it. You might get a headache or things like that. Testosterone gel therapy, why does it go low after stopping? I mean, it should go low after stopping for a short period of time, but typically that's only a brief period and your body will come back up. But when you take testosterone topically, you are going to suppress your own body's normal production, just like you're going to suppress sperm production. And with sperm, about 90 to 95% of the sperm production will come back. And we don't know exactly what it is because there's a lot of variables, how long you took it, what were your numbers beforehand, what was the time frame and your age beforehand, because it could have just been, the numbers were going to go down anyway. But, there's some things you can get to do around that. How many treatments for shockwave? Usually 6. Take 6 visits, $2,000 for all the visits. A lot of questions about shockwave therapy. The cost of the injections are cheap. Usually once you get started, it's less than $5 per shot. Once you get an implant, you burn bridges. So that's the other thing about an implant. Once you get an implant, if you're one of that 5 or 10% or whatever that says, I don't like it, yeah, I can take it out, but that may mean nothing works. So we want to be sure we've tried everything first. That's kind of why I do it. Yeah, I mean, there's a question about, can shots cause scar tissue? It's possible. It's also possible you're just an older man who's developed scar tissue, because that's what happens with Peyronie's, which can affect 10%. So it is possible that shots could cause scar tissue. I just don't see it that much. So I think that's all the questions we have. And unless there's any other questions, I think 45 minutes is pretty good. So again, my name's Kevin Campbell. I enjoy what I do because I can almost always help. I'm sure there's a way you can, our moderators can tell you how to get a hold of me, and I appreciate your time. Thanks so much.